All right, let's talk about skin. It's our biggest organ, right? And for any medical trainee, learning to read its signs is an absolutely crucial skill. So in this explainer, we're going to give you a framework to do exactly that. We'll help you figure out how to tell a simple rash from something more serious. Okay, so you see something like this, a superficial spreading melanoma. Yeah, that can be pretty intimidating. But here's the thing. Every single spot, every rash, every plaque on the skin, it's telling a story. And the key really is just knowing how to read that story. And that's what we're going to do. Over the next few minutes, you're going to learn how to read it. We'll walk you through a systematic approach, starting with the basic language of dermatology. That way, you can feel confident describing, diagnosing, and even managing the common stuff you're definitely going to see in your training. So let's jump into our first section. Where do we even begin? Well, it all starts with being able to accurately describe what you're seeing. Seriously, in dermatology, morphology, which is just the fancy word for the form and structure of a lesion, it's everything. So, you see a patient with a rash. What's the very first and most critical step? It's not jumping to a diagnosis. Nope. It's giving a detailed description. You got to characterize the lesion itself before you can even think about naming the disease. Why? Because that description is the key that unlocks your entire differential diagnoses. And that process begins with identifying the primary lesion. Think of this as the original clue, the initial change. These are the lesions as they first appear, before they've been scratched or picked at or just changed over time. It's the purest presentation of the disease. Let's take a macule, for example. Super simple. It's just a flat, colored spot. Think of a freckle. It's a change in color, but there's no change in texture. Here's a good test. If you closed your eyes and ran your finger over it, would you feel it? Nope, not at all. And this little diagram here shows you exactly why. You can see how the epidermis stays completely flat, totally level with the skin around it. It's purely a change in color, nothing more. Okay, so now let's contrast that with a papule. A papule is different because it's a small bump that you can actually feel. Think of a regular mole or maybe a whitehead in acne. This is a lesion you can palpate. And check out this diagram. It shows that elevation perfectly. See how it rises up above the normal level of the skin? That feeling, that tactile information is an absolutely crucial diagnostic clue. Now, what happens when a bunch of these little papules group together? Well, when they coalesce, they can form a plaque. This is a bigger, raised, kind of plateau-like lesion. Just think of it as a wide, elevated area that you can feel. We see this all the time in conditions like psoriasis. All right, section 2. Now that we've got some of the basic lingo down, let's actually apply it. We're going to look at two of the most common inflammatory conditions you will definitely encounter, eczema and psoriasis. So here they are, side by side. On the left, you've got eczema, and on the right, psoriasis. Even at a quick glance, you can see they look pretty different, right? Eczema often looks kind of ill-defined and scaly, but psoriasis, that has that classic thick, silvery scale.
So, what are the big giveaways? Two things. Location and appearance. Eczema loves the flexures, the crooks of the elbows, the backs of the knees. It can also cause what we call lichenification, which is just a thickening of the skin from all that scratching. Psoriasis, though, it's the opposite. It loves the extensor surfaces, like the outside of the elbows and knees. And look at the morphology. It shows up as well-demarcated plaques. That means they have really sharp, clear borders. They're red, and they have that signature silvery scale.
This pattern of where it shows up the distribution is such a powerful clinical clue. It helps you narrow things down so fast. I mean, if you see plaques on a patient's elbows, your brain should immediately be screaming psoriasis. Okay, let's switch gears. Section 3. We're moving on to another incredibly common condition, acne. And with acne, understanding its pathogenesis, the why it happens, is totally key to figuring out the what of how to treat it. So, acne isn't just one thing. It's actually a 4-part process. Step 1, a hair follicle gets plugged up. That's what we target with things like topical retinoids. Step 2, the sebaceous glands go into overdrive, producing more oil, or sebum, which fills that plug. Step 3, a little bacterium, Cutibacterium acnes, sees this oily plug and thinks, great place to live. This is where antibiotics come in. And finally, step 4, the body's immune system freaks out and mounts an inflammatory response, which gives you those red, angry pimples. The cool part is, each one of these steps is a potential target for treatment. All right, on to our last section, section 4. Let's take all those descriptive skills we've been talking about and use them to tell apart a few common skin infections that you are absolutely going to see. This table here is a great summary of 3 big ones. And notice the language. The description is everything. When you hear honey-colored crust, your brain should immediately think impetigo. That's a classic clue. For dermatophytosis, which you might know as ringworm, you're looking for annular scaly plaques, ring-shaped scaly patches. And for candidiasis, the keyword is satellite pustules, especially in skin folds. Learning these classic descriptions is all about pattern recognition. And here's a perfect example. What you're looking at is tinea pedis, a fungal infection of the foot. Look at that characteristic moccasin distribution. It covers the sole, the heel, and the sides of the foot, just like a moccasin would. Seeing that pattern is so suggestive of the diagnosis, you're already pretty sure what it is even before you scrape it for a KOH prep to confirm. So let's wrap this up. The whole point of this isn't just to have you memorize a list of diseases. It's to give you a reusable mental model that you can apply to any patient with a skin complaint. Just remember the 3 steps. 1, describe the lesion. 2, note the distribution. And 3, consider the underlying process. Describe it, find it, and think about why it's there. So now you have the framework. What's the first question you're going to ask yourself when you see your next patient with a rash? Remember, it's not what is it? The first question is, how would I describe it? Once you start there, you have the tools you need. You're ready to start decoding the stories that the skin is trying to tell you.